Hello everyone, Dr. Gates here. God has blessed me with so many gifts. God spared my life for more than 5 decades to be able to develop these gifts so that I can help somebody along this journey. And I thank God for that. Every day I awake is a day to teach on social media. That is why I have more than 5,000 posts on social media. Be it to teach about biology as it relates to medicine, or social and psychological discussions, including mental health issues as it relates to medicine. So here I'm about to show a case to show healthcare disparity in our community. Another example of such, in fact. I posted an autopsy case recent on social media. And I discussed, or at least I showed what appeared at the time, what I thought to be a cystic lesion in the retroperitoneum. And I thought it was going to be a hematoma of some kind. Well, it turned out to be a large, it was a vein, but it was the inferior vena cava that was dilated and obstructed by necrotic tumor and atheromatous clot. But I want to show you how this tumor arose in the background of a primary cystic kidney disease. Most of the tumor was in the pelvic area and along the intracystic space. It was microscopic from that standpoint because I didn't see it grossly, but I can tell that the tumor basically expanded the pelvis and went into the inferior vena cava. And from there, essentially continued to grow in that inferior vena cava until the person obviously succumbed over many, many years. So she never received a CT scan, obviously, but relegated only from a clinical standpoint as to what may have been the cause of her renal insufficiency. But I selected a few slides to show you. One here is the actual primary kidney, showing the tumor in the kidney, and there is a section of liver showing a microscopic focus of what most people would have presumed to be some sort of proliferative lesion, but I think that's going to be tumor, and I'm going to show you why I think it's tumor. And then the other two slides will be, here is the inferior vena cava, that first slide, and there is part of the tumor section that I took out of the inferior vena cava to show you, indeed, that's all metastatic renal cell carcinoma filling up the lumen of the inferior vena cava. So I plan to show you that. But before I show you the pathology slides of selected images, I want to first show you the anatomy of the area of interest. So I'm going to pause the video to show you the anatomy that we'll be talking about. So here's the area of interest, and I'll point out what I'll be talking about, but I wanted to kind of show you this this anatomy part first, because, okay, here's the kidney, here's the right kidney, and there's the left kidney. And I wanted to show you the proximity of the kidney as it relates to where I think the tumor may have started right in here and grew into the renal vein and obviously into the inferior vena cava. This is where blood is carried from the lower part of the body and it returns to the heart. So the inferior vena cava travels up through, obviously in this area will be pancreas and transverse colon and liver and all of that. And I explained, I point that out because that's where we saw some of the changes on the gross autopsy. But the inferior vena cava returns blood back to the heart so that it can be returned to the, pumped to the lungs to get reoxygenated and then returned back to the heart, eventually going out of the aorta to send oxygenated blood back through the upper and lower part of the body. So anyway, I wanted to kind of show you this view here, and as it relates to where we'll be discussing where the tumor arose and how it extended into the renal vein and ultimately into the inferior vena cava. So for 30 years, this lady was routinely under the care of a major health facility here in Atlanta. And in spite of her familial history of a sister and other family members dying from primary kidney disease, she was never diagnosed as to what was the etiology of her primary kidney failure and or disease, only being relegated as it to be related to diabetes and high blood pressure, which is oftentimes too many people are declare that their kidney problems are due to high blood pressure and diabetes without really evaluating the true etiology of the kidney problem. And so this is just another example to highlight the disparity in healthcare among Black and brown people, because I believe that had she been appropriately evaluated perhaps 30 years ago, as you can see that this tumor looked like it has been around for some many years, and perhaps was just neglected in terms of neglected in terms of being discovered by perhaps a CT scan when something perhaps could have been done sooner. So let's get into the discussion. So we'll begin by perusing around at this power of the kidney. That in the center is a relatively normal glomerulus, okay? And then you can see some of the surrounding renal tubules as being necrotic with the little pink, hazy looking cells around them. So that's acute tubular necrosis from the tubular standpoint, from perhaps hypovolemia from obstruction. But we'll get more into that as I continue to peruse around. You can see some little patchy interstitial inflammation. And then you start getting more into complete sclerosis of the glomeruli, a couple of glomeruli there. And you can see some fibrosis around some of the arterioles. So let's just keep on perusing around until we get into the kidney, into the tumor itself. So we're going to keep on perusing around more abnormal glomeruli. There's one at the 12 o'clock that looked relatively normal, but you can see some fibrin deposit even into that glomerulus. And you can see more completely washed out either arterioles or glomerulus, okay, from kidney disease. All right, so more acute tubular necrosis as we continue to peruse around, a little interstitial nephritis. All right, so we're going to keep on perusing around until you hit the tumor. And I don't want to belittle the point here. Let me go to a lower power view, so we can go right into the tumor and have most of our discussion regarding that. But you can see that there's glomerular disease and both tubular disease before we show the tumor. And now we're getting into the tumor itself. All right. And we'll go down to higher power to see the tumor, but you can see that there's some necrosis of this tumor here. And I think that's all a part of the renal pelvis. So the tumor is growing in the renal pelvis there. All right, there's more of the tumor. And we'll go to a higher power view so you can see that, but it has this clear cell, apparent clear cell feature. And there's you can see some micropapillary component as well, or papillary component as well. But we'll talk more about the tumor once we go down. In fact, let's just do that now. Let's just go on down and see the tumor itself so I can convince to you that that is indeed renal cell cancer. All right, and you can see more clear cell features from there. And you can see, let me see if I can go down. And the cells look not that bad in terms of anaplasia. I mean, there's some nuclear anaplasia, but most of it is well-formed, clear cell with abundance of clear cytoplasm and inconspicuous nuclei. But you can see that that's definitely clear cell tumor cells here, as we continue to peruse around just to show you the cytology. And I highlight the cytology part because you're going to see these same bland looking tumor cells in other, like in the liver and in the inferior vena cava as well, as I discussed before. But you don't see not much in the way of mitosis. And again, there's nice clear cell differentiation right there. Again, with centrally placed, for the most part, hyperpigmented nuclei. And so just going to keep on going around as we look at the gestalt of the tumor cells itself. And let me see if I can go to a lower power view and see more. There is some necrotic tumor there. And As we continue to peruse around here, you see the now that might be a vein there that is growing in already, or it could be the renal pelvis, because it can look like vascular tissue, but it's actually connective tissue from the kidney itself. And you can see more of that. Let me see. I'm going to go kind of peruse around some more so I can, I don't want to just belittle the point here. Let me see. So let me see. But but I didn't see this grossly, and now, you know, the tumor was, you know, each tumor weighed, one was like 100 grams and the other one was 90 grams. So they were small size tumor, but you can see the tumor was definitely there. There's tumor there. And so let me just keep on going around so you can see the overall gestalt pattern of the tumor. There's some papillary-like growth pattern as well, but most were like clear cell, tubular clear cell. Okay, as I continue to go around, not much in the way of anaplasia, slight anaplasia, but mostly well-formed tubular nuclei, some hyperpygnotic, but nothing in the way of prominent macronucleoli. There is some necrotic debris there within the tumor cells there as we continue to go around. So with that, okay, I think you can see where I'm going from this, and I want you to put this image in your mindset, in your brain, so that when we do see the tumor elsewhere, you'll see why the tumor can be extreme. Particular, notice this area right here, can be extremely deceptive in terms of not thinking that this is cancerous tumoral growth. So we're going to go to the next slide. So before I go to the inferior vena cava to show you the tumor involved in that, I want to show you the liver. There is some microvesicular steatosis, and there was some necrosis as well. So here's one area that I wanted to kind of highlight. Now, your immediate impression that, no, this is a portal tract with perhaps bile duct expansion or proliferation, and that might be the case in this particular one. But I want you to notice this area. It might be just bile duct proliferation. You see some pigmentation, maybe bile pigmentation staining there. So let's go to another area, because I think I had a better area in view to show you that I think is going to turn out to be a little focus of metastatic cancer. So you can see that the liver overall not bad, other than the microvesicular steatosis. Again, I believe may have been chemically related. She was on opiates and benzodiazepines, but and some of the, and I think those are kind of broken down in the liver, so you see some toxicity from that. But didn't think it had any bearing on her survival or okay, there, now that's definitely bile duct proliferation, that portal triad there. So we're not going to look at that one. So I just want to keep on scanning around. Now I know I saw it, so it's just going to be there it is. So when you look at that, there's not a portal area. So that's abnormal. So we're going to go down to that little focus there and see what those cells are about. All right. So they had that slit-like, almost you think immediately maybe vascular angiomatous looking proliferation in the liver. You can see a lot of those all the time. But then you start being very careful with examining the cells themselves. And those cells are beginning to look like clear cell nuclei. And then you're going to see that while these cells have been there for some time, so they're going to be kind of degenerative looking. But as we continue to go to peripheral, you can see that some of them now are taking on some clear cell morphology from the cytoplasm standpoint. And of course, like I said, these cells are dying, so they're not going to have the same morphology. And you can see there's a little necrotic liver tissue there as well from the obstruction of the vein itself. So let me just keep on perusing around. I think that, let me see if I can go to, I don't know if I have another power. Okay, let's see. Nope. Oh, yeah, maybe. Let's see if it comes in focus. No, that's on the oral immersion, so we're not going to get anything out of that. So we're just going to go back to a low power. We're going to end this the sections of the liver, but you can see that there is some zonal necrosis there, microvesicular steatosis, and that little microscopic focus. It's the only focus that I saw in this liver that I think is indeed metastatic renal cell cancer. Okay, so now let's go to the meat of the discussion itself. So this is that section of the inferior vena cava wall. This is the wall of the inferior vena cava. And let me see if I can zoom out. Maybe not, I can't. All right, so I'm going to zoom back in. So I just want to show you the inferior vena cava first. It's all scar tissue with a little inflammation in the wall. And more scar tissue in this inferior vena cava. Very scarred down inferior vena cava, inflamed as well. And as we continue to peruse over, this is still the exterior part. There is some necrotic debris from, you'll see where that is from once we get into it, but we're not going to discuss that here. We're going to discuss that later. And then let me keep on going around so you can see there's more inflammation in that wall and the adventitia of the inferior vena cava. So this was pathology for some time. You can see the scarring, fibrosis here. Let me see. I wanted to show you there's some calcification there. And let me see. I wanted to show you how I know that this is inferior. Well, I know because I took the section from the lesion itself, and then the gestalt of the histology is that of a large vein, that being inferior vena cava. But let me see. Okay, there we go. This is what I wanted to show you. So this is obviously around the luminal area. You can see some necrotic bacteria. You can see some cholesterol clefting from the clot and cellular debris. There's more inflammatory cells. Now, I think most of those are perhaps histiocytes. Now, could they be floating renal cell cancer? Very possible. I think those are inflamed and scarred tissue from this atheromatous plaque and clot. So let's go to the meat itself of the vein. I actually took a sample of what I thought was all necrotic debris and clot, and it turned out to be a necrotic tumor. So let's go to that area now. All right, as I peruse around first, there's a more definitely area of, let me see if I can get it in focus. Yep, that's atheromatous clot. You see some recent and remote hemorrhage there. That's all in the lumen there of the inferior vena cava. And just keep on, we just keep on perusing some pigmentation from bleeding, remote and recent hemorrhage there. And then obviously the clot. That's all clot right there. So let's see if we can keep on perusing around. Now, this is the tumor itself. And most of it, I agree that it's all necrotic, but that's all renal cell tumor filling up that vein, that lumen. And let's see if we can go down, because just to convince you that those are outlines of cells, it's not debris. Those are necrotic cells from a renal cell cancer filling in the lumen of the inferior vena cava. See the cellular outlines, all necrotic, albeit. So I don't know if if they diagnosed this. But apparently the next of kin didn't think she had this. So I don't know if they diagnosed it, treated, just felt like it was too advanced before them to treat. And but this is all necrotic. Or did the tumor die itself because it was in a part of the body that didn't have any structure, it was just floating into the wall of the vena cava, inferior vena cava. So those are definitely the tumor cells, albeit mostly necrotic. And I did see one focus in the wall. Let me see if I can get to the wall. That had maybe a residual viable tumor cells. I don't think that's it. I'll get to it. But you can see how large this tumor is. Okay, I think it is coming up. Let me just keep on viewing it. Right, that's still all tumor, necrotic tumor. Okay, and right here in this focus right here, I think that's going to be viable tumor cells right there. And you can see it almost has the same resemblance as the tumor cells in the primary kidney in that pelvic area. So that's those are tumor cells, renal cell, clear cell renal cell cancer that were viable in the wall of the inferior vena cava. Okay, and see, notice that's what I was trying to bring out with the nuclear features are not that bad. Maybe a little low grade, hyperpignotic, hyperchromatic nuclei, but very centrally placed with abundance of clear cytoplasm, pale pink to clear cytoplasm. So those are tumor cells. All right, so that's the end of this discussion. Thank you for watching it, but it shows that we got to do better. And I'm going to link one of the things that I posted before. You know, after 35, 45 years old, I think it's a good idea to do some basic labs and some imaging studies. And even if your doctors don't order it, you can still go to any lab or a physician like me, and we'll do some preventative measures and see what's really going on, not only with your anatomy, but physiology as well, but more particularly the anatomy, as in this case, this person had this tumor growing for some time that was never diagnosed. Thanks for listening to the video.